So I want to thank you very much for inviting me to speak today. How many of you were at my presentation yesterday? Can you show your hands? Not very many. So for you, I apologize that I'm going to repeat a few slides from yesterday about the Veterans Administration so that the others can understand the organization. I will tell you that before I came here, my sister, who's done a lot of genealogy research, told me that our relatives were from Basque, France. And she said, people from Basque France have very special genetic material, very special. And only the people from Basque have that and carry it. And I thought she was over-dramatizing, as my sister does. But I talked to Luke yesterday, and he said, that's true. So I am, in fact, French, and I have special genetic material. So yesterday I spoke about how the Veterans Administration is providing integrated care outside of the walls of our healthcare institutions. Today I'm going to talk about our strategy for empowering the consumer to better manage their own health. This is a slide to show that I think the French and the healthcare systems have similar problems. We're both suffering from a strain on our resources because of increasing age in our populations, an increasing cost of the treatments, and an increasing number of people with chronic diseases. We also have similar that both of our healthcare systems rely heavily on private insurance to fund healthcare, and also both systems still rely heavily on fee-for-service. Fee-for-service reimbursements have a perverse incentive for driving overutilization of care. The U.S. is moving towards bundled payments as a way to fix that problem. But it's slow, and we've only done it for 3 cohorts of patients. The VA, where I work, the Veterans Administration, is run as a separate government healthcare system apart from the U.S. healthcare system. It's designed to serve a unique cohort of patients, which are those individuals who have served in the armed forces. In order to be treated in the VA, you must enroll in the VA. And we have approximately 9 million people enrolled in VA healthcare. There's 16 million people who are eligible, but only 9 million of those people have enrolled in healthcare, and we see about 6 million people a year. We have a budget that's allocated by Congress every year. Our current budget is $65 billion a year. The way that budget is formulated is through actuarial projections. They project the number of enrollees that will use our services and the types of services that they will use. The VA delivers the majority of its care through our institutions. We have 170 medical centers. We have over 1,000 community-based outpatient clinics. We have about 130 nursing homes, and we have over 100 residential care centers. About 12% of our care is delivered in the community by community providers whom we pay for in order to deliver the care. We also have 335,000 employees. I'm very proud to say that the VA is an integrated healthcare system, and by what that means is that we combine social care with medical care, and everyone must know that a large component of health is socioeconomically driven. And so we believe very strongly that you need to help people with housing before you can help people with medical care, and that is the type of system we run. We also provide different services than what's available in the community. We provide a much greater array of mental health services, and we also provide a larger amount of specialized services for war-related injuries, such as prosthetics and traumatic brain injury types of services. However, it's important to remember the VA is not a closed system. We are not a health maintenance organization. Only about 1/3 of our patients receive all of their care from the VA. 2/3 receive some of it from the VA and some of it from other healthcare organizations. That becomes particularly acute when they turn 65, because in the US we have another government-run system called Medicare, and Medicare pays for health care for people who are over 65. So when veterans turn 65, they begin to use a lot more of Medicare-funded services. I will say that our population that we do serve is 40% sicker than the community patients, the comparable community patients in the private sector. And by that, I mean the number of chronic diseases that the patients that we see is much greater than patients seen in the private sector. The VA is required to treat all eligible enrolled veterans within the budget that Congress has allocated us, regardless of where they live. And that is a very large problem for us. The United States is a very large country with a lot of rural areas. 25% of our population lives in rural areas, and only 10% of our providers live in those rural areas. The VA has built hundreds of community-based outpatient clinics to try to address our access issues. About 12% of our vets live more than 3 hours away from a major medical center that the VA owns. And so in order to try to tackle the problem, increasingly VA is using digital technologies to reach out to veterans who live in rural communities. In 2014, we had a crisis in the VA. It was not our first crisis in the VA. We have them periodically. But this one was about access. We've had access crises before. But what happened was there were certain locations where there were long waits for care, and that was covered up by the directors of the medical centers where patients were waiting. And when it was revealed, it was a crisis, and many people lost their jobs in the VA as a result of it. And Congress stepped in, and VA had to look at a new strategy for dealing with access. And it was twofold. Well, the first was to use community partners more than we have, and to reduce our reliance on our own services. And second was to increase our use of technology to improve access. So using technology, we developed 4 strategies for using technology. The first was to try and deliver care where the patient is located and not make the patient come to us. The second was to leverage the size of our national organization to better match supply for healthcare resources with demand. And we developed telehealth hub and spoke models. The hubs are where we can hire providers, and the spokes are where we cannot, or where it's difficult. And we use video conferencing technology largely to connect specialists at hubs with patients and spokes. I talked about those 2 strategies yesterday. Today I'm going to talk about the last 2 strategies, which is 1, how to empower patients and their families to better care for themselves, and 2, how to improve communication and data exchange as a way to improve the healthcare we deliver. So our office, the Office of Connected Care, where I work, is employing multiple modalities of care, of technologies to improve the access points for VA healthcare. So for example, we're using text messaging applications, mobile health applications, video care like Oscar, similar in some ways, remote monitoring, or as my colleague from Sanofi said yesterday, it's better termed remote surveillance, store and forward, which takes digital images at a community CBOC and forwards them on to a specialist at a medical center to review, and then our patient portal. So I'm just very briefly tell you, the office that I work for is called the Office of Connected Care, The mission of Connected Care is to expand the reach of healthcare using technology. There's 4 portfolios in Connected Care. There's the telehealth portfolio that's run by my colleague, Dr. Kevin Galpin, and about 12% of our patients each year receive telehealth services, over 2 million episodes a year. The other 3 portfolios I manage. The portfolio is our patient portal called My Healthy Vet. That patient portal has been around for almost 12 years. We have 3.8 million people registered in that portal, and it is the 4th most frequently visited federal website in the United States. The next portfolio is our mobile health portfolio. It's a very new in the last 5 years. And finally, the other portfolio is our innovations portfolio. We have over 200 innovations in that portfolio. About 30% of those innovations actually make their way into field testing, and then a smaller proportion of those actually make their way into national production. I did see Mark Bachman's presentation yesterday. I don't know if you all saw it, but there's a part about innovation, and I had lunch with him today, and I said, Mark, well, there's 2 different approaches for innovation. One is that you go in and you have a very targeted problem you're trying to solve, and the other approach is kind of what we do in the VA, and it's just let everybody come up with ideas and see what happens. And my frustration with our approach is we're getting very incremental innovation and not radical innovation. And I think Mark, I think he's in the audience, supported that is one of the things that happens, and that maybe going in with a more targeted, we're trying to solve this big problem, might be a better way to do innovation. I'm putting words in his mouth. But we are struggling a little bit in my organization with how to do innovation. The first digital health strategy that I'm going to talk about is how to empower family members and patients to self-manage their care. There's basically 3 ways of doing that we've come up with. One is to make resources available to them easily. The second is to develop self-service capabilities. And the third is to promote self-education and peer support. So the slide in front of you has the resources that we're trying to make easy. The one on the upper left is called vets.gov. It's the main entry point for the VA. It's the way you access VA health resources, cemetery resources, education resources. It's the main door. The one on the far right is our patient portal. It's where you get all of your health-related information. And the one on the bottom is our mobile app store, which houses our mobile applications. The difficulty has been trying to create a seamless experience across all of these entry points and to make sure that they're logically connected. Just want to make one point about our patient portal. Patient portals are used widely in healthcare organizations, and there's quite a bit of literature showing that they're very effective in helping patients manage their health. We did a study in the VA, and we showed that our patient portal reduced urgent care visits. Kaiser Permanente did a study, and they showed that the use of the patient portal actually increased measures of prevention, which we call HEDIS measures. And Group Health was another company or a healthcare system that used the patient portal and studied it, and they were able to show that rates of depression were lower in patients that used the patient portal than those that did not. So the next slide is about creating self-service capabilities. We have the ability to refill prescriptions on our patient portal. 15 million prescriptions are refilled through our patient portal a year. We're just completing the development of a mobile app that does essentially the same thing in a mobile app form. The other thing that we did in January was we released a new app that allows patients to schedule their own appointments. And this was one of the hardest things I've ever done in my 32 years of working in the VA, because it came on the heels of that whole a crisis, the wait time crisis, where people were accusing VA of covering up our wait times and our access problems. So this app actually exposed availability of our clinic slots. It started with primary care, and then in the fall we're rolling out mental health, audiology, and optometry. This is a huge business change for VA, and it's really required a lot of organizational change management to move to exposing availability and letting veterans compete with schedulers to take slots to see patients. The next set of slides is mobile apps that promote self-education, and I'm going to tell you we have a lot of them. There's nothing very special about them. They're not all that different from the thousands of apps that you can find on the App Store, except they have a VA bent to them. They're fairly easy to develop because they don't connect into our healthcare systems. The next slide set is going to talk about the hard apps, the ones that take years to develop, because they connect into our healthcare systems and they require changes in the way that we do business. Oops. I just went too far. So the next slide is our second strategy, which is we are going to improve healthcare by improving the communication that occurs between patients and their providers. And we're going to do that through information exchange, allowing patients to provide patient-generated data to healthcare providers and making that data interoperable and shareable. So we've started down this road. We started early on with secure messaging, which is just a way to email your doctor. We've found this to be quite effective. We have 1.8 million people emailing their clinicians. But where we're going next, and this has been very hard, is how do we create a portal so that providers can see and make use of all of the data that patients are sending. And that's been our biggest challenge, working through that. So before I go into the apps that we've developed that do that, I want to talk some basics. Patient-generated data, we believe, there will be a tsunami hitting the healthcare organization of patient-generated data. It will far eclipse any EHR, electronic health record data, by far. And the challenge to every organization is going to be, how do you take that data? How do you make that data actionable by clinicians and by patients? And that involves a lot of analytics and artificial intelligence. But first, you also have to make that data exchangeable. And so that's one of the things that we're working on. We in the VA have mapped all of our patient-generated data to the FHIR standard. FHIR stands for Fast Health Interoperability Resource. It's the next iteration of HL7 without the Z segments. If you know anything about HL7, you know everybody created their own Z segments, and so it stopped being interoperable. So FHIR is a way to get your data to be interoperable. We in the VA have mapped all our patient-generated data to the FHIR standard. We built a FHIR API. Any mobile app that reads or writes patient-generated data must do it through our FHIR API. And that ensures that the data will always be standardized and interoperable. We started early on with the concept of patient-mediated data, and this is really important. We were really frustrated with the slowness of the healthcare system to really get on board with exchanging healthcare information. It just seemed like we were waiting and waiting and waiting, and we were going nowhere. And so we said, you know what, let's put the patient in the driver's seat. Let's give the patient the tools to be able to exchange their information. And so we started early on with Mobile Blue Button. The VA, I don't know if you've ever heard of Blue Button, the VA was the first healthcare organization to develop it. The concept was that patients who own their health record data should be able to mash a button and have that data come down into their device, either as a PDF or an XML, and they should be able to share that data with whomever they like. That was step one. Step two is that we in the VA and other healthcare organizations will FHIRize our data. We will register our FHIR endpoints so everybody knows who's sharing, who can make their data shareable. We will standardize around OAuth 2 as our authentication system across healthcare organizations and create apps that will allow patients to move their data from one healthcare organization to another. That is our vision for how we're going to reduce the fragmentation of data in healthcare. And the fragmentation of data in healthcare is one of the key reasons why we don't have good coordination of healthcare and why we have the errors that we do. So I'm going to talk now about some of the apps that we've developed. I want to first tell you we've developed a app for the providers, and it's an app that gives them a view of the electronic medical record, but it also gives them a view into the patient-generated data. Now, it's still embryonic because what they can see is basically the data that the patient has put in. Our goal is to move to high-end analytics and start making this data more actionable, but we're not there. We're just beginning the process of collecting it and displaying it. So the first app is called the Journal Video app. It was developed by patients who are in rehab therapy, and the concept here is that patients need to be able to take videos of how they're progressing in their rehab therapy from home, and they need to send them to the provider. So there's a provider app and a patient app. The provider orders video clips, like 5-minute lengths, 5 of them for a 5-week period. The order is placed, the patient is given an authorization, and the patient can then send the videos into the patient-generated database where they're reviewed by the provider. Excuse me. The next app is the app that I'm most proud of all the apps we've worked on. This is the one I'm most proud of. What was happening in healthcare was that anytime we in the VA ordered genetic testing through tumor pathology orders or drug metabolism orders, the order was sent out to a company. The company would do the testing. The company would keep the results and the data in their own repository. They would send a report back to the VA. Largely, the report had to be faxed to the VA. It wasn't really integrated into the EHR. The clinician would have to read the scanned fax report to understand the genetic testing. We said, no, this is a broken system. What we're going to do is we're going to say, if we pay for genetic tests and drug metabolism tests, you will send the results electronically through our reference network. What that has enabled us to do is it allows us to collect the reports and send them both to the providers and the patients and begin assembling the clinical data of the patient. So we start assembling the data. Maybe tomorrow someone learns that a specific genetic mutation is associated with some new thing. We can go back and look at the data and see who has that genetic mutation. The other thing that's very empowering for patients like me, I am a slow metabolizer of codeine. So I'm always having this fight whenever I have pain and need it, that you need to give me more, and I'm not a drug addict. I just metabolize it faster. Now I actually, as a patient, have a report from a reputable genetic testing company that shows that I am a fast metabolizer of codeine. And that really empowers me as a patient to take better control over the types of drugs that are prescribed to me. And there's a lot of research going on. People metabolize antidepressants differently, and this information will help both the providers and the patients get the right drugs. I went, again, too far. I'm going to kind of go fast through these because I'm not sure how much time I have.
Very short time,
Very short.
please.
Okay, I'm going to talk fast. Mental Health Pro collects patient-reported outcomes for mental health patients. We used to have them come in for a visit. Now we can collect the information from their home. The Pain Coach, the same thing. Patients can provide information about their pain in great detail, and it goes to the team to better manage it. Dementia Care is for the family members who record the activities of daily living about patients that they're taking care of, and it goes to the neurologist to help manage dementia. Fit Heart is for cardiac rehab. Teledermatology is much like the journal video in that the patients send pictures, they receive an order to send pictures, and the pictures can come in and be reviewed by the dermatologist. And the mobile kidney is an app that helps patients and their providers manage chronic kidney disease. The blue button data, I talked about patient-mediated data exchange. I won't cover that again. Wait, I'm going backwards. Okay, the My Journal app, it is an app that allows us to customize and personalize our care. It collects many, many things from patients. The key thing here is it collects goals from patients so we understand what's important to them, and also that collects their view of their medications and the side effects that they're experiencing from medications. One of the reasons that we have so many medication errors is because the medical community doesn't really understand what the patient's view is of their medications. What they think they're for, sometimes it's completely wrong, and what side effects that they're having, which is why they're not taking them. So this is our ability to get the patient's world in front of the provider. Last thing I'm going to talk about is Annie. It's a text messaging application. We stole it from the UK, NHS. It is a disease management protocol text messaging system that's based on disease management protocols. So what happens is you enroll a patient in a disease management protocol, such as hypertension. Annie, nurse Annie, sends a message to the patient and says, it's time for you to send your blood pressure. And the patient will send the blood pressure back in. The computer will read what was sent in, and based on the value, there will be algorithms behind the scenes that are constructed to respond back to the patient about what to do. If the patient forgets to respond, Annie will gently, nicely inform them that they need to send the reading in. The data does go back into the patient-generated database. It is accessible by the clinical team, but the clinical team is not responsible for responding to alerts or notifications about the data, and the patient is told that. Annie is responsible. The computer algorithm is responsible for responding. The last thing is we believe very strongly that you have to have evidence for this technology, and we've got 4 research initiatives going on in the VA. One is around Annie and text messaging and how to implement that and get adoption by clinicians. Another is secure messaging, the impact of secure messaging on access. The preliminary data has come back on that and shown that secure messaging actually improves perceptions of access. The fourth, which I just love because it was my idea, was that let's do something like the Framingham study. Do you know what the Framingham study is? It's a heart study that they took baseline data on people for over 20 years, and they followed them for a long time to see how their behavior affected heart failure, heart disease. Well, we developed a cohort of patients, 3,000 of them, that had some familiarity with text messaging, with technology, because they were using email, secure email. We collected baseline data on them, and every time we produce a new technology, we give it to this group, this cohort, and we assess what is the impact of that new technology on this base cohort, so we can begin to understand the impact of technology on patients. And finally, we have a study where we're giving patients in rural areas or patients who have barriers to receiving care iPads to understand the impact of the iPads on their health outcomes. So with that, I will say that the VA has a long history of using technology to improve healthcare, and I'm very proud to work for the Department of Veterans Affairs. Thank you.